Good evening, my friends, my colleagues. Today, the wave 2 of the ALIVE program, which is atrial fibrillation value education. As you know, that last year we have 6 waves with the ALIVE program and was very successful. And this year, this is the second wave. This sponsored by Pfizer and technical parts by ICOM company. We have our distinguished speaker today, Dr. Jeffrey Browns. And we have panelist Professor Hisham Abu Al-Ainin from Professor Cardiology, Banha University, with Professor Walid Ammar, Professor Cardiology, Cairo University. And then 2 cases, one by Dr. Shihab Al-Atrabi, lecturer of Cardiology, Ain Shams University, and then Dr. Sharif Wagdi, assistant professor in Alexandria University. As you know, that the atrial fibrillation now it's very common to find atrial fibrillation. You have guidelines for arrhythmia, for atrial fibrillations, for atrial fibrillation special situations. So our rule in the ALIVE program is to illustrate the anticoagulation, the antithrombotics, the difference between all of them, what the guidelines say, and then we go to different case interactions. Please look to the NE lecture and then give me the questions. Then, so I distribute to the panelists. So I will start with Dr. Jeffrey Douglas Barnes. He's Assistant Professor, Cardiovascular Disease, Internal Medicine. Dr. Barnes' clinical interests include treatment of vascular disorders, including venous thromboembolism, peripheral arterial disease, renal disorders, anticoagulation, and general cardiac care. Before Dr. Barnes, I saw him and I was moderating sessions at the ECC. He's a very nice guy. He's very informative in the field of thrombosis. So I admired his talks, and I promised that I will bring him to the ECC Egypt ALIVE program under the umbrella of ECC chapter in Egypt. My name is Mohammed Sobhi, Professor of Cardiology at Alexandria University, and President of Severity of Foundation, Governor ECC chapters in Egypt, and Steering Committee of ECC chapters Middle East and Africa. So we start to Barnes. The floor is yours.
Well, Professor Sobri, thank you so much, and it's really an honor to be here. My only disappointment is I can't be with you all live. Egypt is one of many countries that I am eager to get to visit because I just hear it is so beautiful and amazing. But thank you for inviting me to present. I'm going to start out with just a general review of oral anticoagulants, talk a little bit about what some of the anticoagulants are, and then talk about some of the newer data that we have especially as it interfaces with patients who have atrial fibrillation. And that'll sort of be the first talk. We'll move into the guideline piece in the second talk. I do have a few disclosures, and they largely relate to companies who make different anticoagulants that I've done some consulting for. You know, I find it's often helpful to think about the timeline. How did we get to where we're at today? And this is a rough timeline of anticoagulation. You know, you start back in the mid-1930s, and this was really when the first IV form of heparin was introduced, really our first anticoagulant that was available for clinical practice. You fast forward about 2 decades, and this is where we get a vitamin K antagonist, or warfarin, introduced. And really, for the rest of the 20th century, those are the 2 drugs that dominate anticoagulation therapy. You've got an IV form in heparin, and you've got an oral pill available in warfarin or any of the other vitamin K antagonists available around the world. But then towards the end of the 1900s, so 1980s into 1990, this is where we start getting some of the low molecular weight heparins. We start to refine heparin. It becomes a little bit easier to administer, a little bit more predictable. Now, in 1986, the American College of Chest Physicians said, well, there's a lot going on with anticoagulation, whether it's venous thrombosis or atrial fibrillation or, surgical patients. We need to put together a comprehensive set of guidelines to help manage and guide clinicians who are caring for patients on anticoagulants. But as we move into 2010 and sort of the last decade we just went through, things really have taken a paradigm shift. We've moved away from heparin and vitamin K antagonists as the centerpieces of anticoagulation to now having this whole new class of direct oral anticoagulants available. And in the US, the Federal Drug Administration, as well as in Europe and most other countries, began to approve these drugs sometime from 2010 onward. And in addition to approving them for the most common indications, atrial fibrillation and venous thromboembolism, we also are now seeing some expanded indications, places where we're using oral anticoagulants that we traditionally have not used them before. And I'm thinking about things like peripheral artery disease, even coronary disease, cancer-associated thrombosis, and some of those areas. And so there's really been a lot of excitement here in the last 2 decades in the field of oral anticoagulation therapy. This is a table that summarizes some of the most important points of the various oral anticoagulants are available. A lot more detail can be found on anticoagulationtoolkit.org. I put the link at the bottom. There's plenty of other websites that do this. Let's sort of walk through these and compare the different therapies, what's similar and what's different. In the far left column, that's the column labeled warfarin or Coumadin. You could really replace that with any vitamin K antagonist. Remember that these are drugs that target 4 different clotting factors, factors 2, 7, 9, and 10. What's really distinct about it is not only do they target multiple factors in the coagulation cascade, but the effective half-life of this drug is exceedingly long. We're talking 40 hours. Which means the time from any change or initiation of this drug until its peak effect is somewhere in the order of 4 or 5 days. Of course, we all know this. We manage patients on vitamin K antagonists. We monitor their INR. And we know if we make a change on Monday, we're likely not to see the effect of that change until Wednesday, Thursday, or Friday. Now, thankfully, these drugs are cleared essentially through the gut and the liver, not cleared at all through the kidneys, so they're safe to use in patients with renal insufficiency. And at least in the US, but I think in most of the world, they're broadly indicated. They have approvals in AFib, in different areas of treatment for venous thromboembolism, and importantly, they're really the only drugs that can be used right now for patients with mechanical valve replacement. We also have different reversal agents available. We have vitamin K, we have fresh frozen plasma, we have prothrombin complex concentrate. So there's a number of strategies available to reverse them if you need. You go to the second column, dabigatran, or goes in the US by the trade name Pradaxa. This is our factor 2 inhibitor, or our direct thrombin inhibitor. Notice that it's not just only targeting a single factor, but it has a much shorter half-life, 8 to 15 hours. And when you take the drug, peak effect within 1 to 3 hours. So I tell my patients, once you take that pill, within an hour or 2, you are fully anticoagulated, being on any of these direct oral anticoagulants, dabigatran being the first we're talking about. Dabigatran is unique. It is the most renally cleared. 80% of it is cleared through the kidneys, which means it's also the most susceptible to problems in patients who have chronic renal insufficiency. In the US, it has approval for both stroke prevention and atrial fibrillation, as well as treatment of venous thromboembolism. However, it's not used a whole lot. I'll show you that on the next slide. And there is a reversal agent directly available for that, and we'll talk about that later. It's a drug called idarucizumab, sort of a tough drug to prescribe, but it does directly reverse dabigatran. The next 4 drugs, Apixaban, Edoxaban, Rivaroxaban, and Betrixaban, as you go across the screen, those are your factor 10A inhibitors. Again, very similar to dabigatran, but just targeting a different step in the coagulation cascade. All have pretty similar half-lives, Betrixaban probably being the longest. The peak time to effect is very short, 1, 2, 3 hours. And they all have variable levels of renal clearance, with Apixaban probably having the least of the commonly used. Now, their indications are quite different, and you have to be careful. Some of them have broader indications, like Apixaban and Rivaroxaban, while others are much more narrow. And in fact, Betrixaban, all the way to the right of the screen, is not even being commercially made and marketed in the United States. So it's really not a drug that's used. We do now have a specific reversal agent for these as well, called andexanet alpha, although it's pretty much limited to the US, and I don't believe it's available worldwide. But there are other strategies, including the use of prothrombin complex concentrates, that can be used to reverse these drugs when needed. Now, I mentioned this before, that we've really seen a shift in the use of different anticoagulants over the last decade. Again, if you go back to 2010 on the left side of the screen, essentially all of the oral anticoagulant being used was vitamin K antagonists. But as you move through the decade, that blue line here starts to decline because it's being replaced by any one of the various direct oral anticoagulants. And you see those designated here in the red stars with the red dashed line. So much so that now, in 2021, the direct oral anticoagulants are much more common for patients who are newly starting oral anticoagulant therapy in the United States. We still have quite a bit of people on warfarin, and they probably will remain on that for a while, but the trend is continuing to shift in favor of direct oral anticoagulants. Initially, that was dabigatran, seen here in the yellow line with the red boxes. That was quickly replaced by Rivaroxaban in the green triangles, and then subsequently replaced with Apixaban, which you see here in the purple X's. And so right now in the United States, Apixaban would be the most commonly prescribed anticoagulant, followed by Rivaroxaban. It's also important to note that while these drugs are highly effective, they do things like prevent stroke in atrial fibrillation, they prevent recurrent deep vein thrombosis and pulmonary embolism, but they also have a significant risk, and that risk is bleeding. In fact, there is data to show that they are the most common cause of adverse drug events that lead patients to come into the emergency department. This is data that was pulled from almost a decade ago, showing that warfarin and Rivaroxaban were amongst the 10 most common drugs that cause adverse drug events in the emergency department. And I would expect that those numbers are even higher now that we have more use of Rivaroxaban and more use of Apixaban, which didn't even make the cut back when this data was pulled. So it's important that we're careful and thoughtful about the side effects and the potential negative effects of these drugs, because we want patients to be able to get the benefit. So we need to make sure we're managing them carefully. What about globally? I've told you a lot of data in the United States. Well, globally, these are also becoming the most dominantly used drugs. I think the Garfield AF registry is one of the best global registries to help us understand real-world use of anticoagulants. This is some data just published here this year from the Garfield group. It was published in the journal Heart, and it looked at data from 2013 to 2016 across 35 different countries. And it even included 367 patients from Egypt there. And what they found, they had a little more than 7,500 patients who were taking a factor Xa inhibitor. They had about 2,000 patients taking dabigatran, one of the direct thrombin inhibitors, more than 8,500 patients on a vitamin K antagonist, and about 7,000 patients who were taking none. And across this cohort of patients with atrial fibrillation, they were at reasonably high risk for stroke, a median CHADS-VASc score of 2. So these patients on average had at least 4 different risk factors for stroke. And some of the results I find really interesting and really poignant. So this is just comparing the patients who were treated with any anticoagulant, that's the OAC, versus no anticoagulant. So in blue is the no anticoagulant group, and in orange is the anticoagulant group. In the top left corner, you see all-cause mortality significantly reduced in patients who received anticoagulation therapy. In fact, about a 2% absolute risk reduction. That's a striking risk reduction. A number needed to treat of about 50. If you look at sort of the ischemic stroke and systemic embolism, that's the box number B. So on the middle of the screen or the top right of the graphs there, you also see that the anticoagulant group in orange is lower than the no anticoagulant group in blue, an absolute risk reduction of just less than 1%. But that comes at a cost, and that cost is major bleeding. You can see the anticoagulant group in orange, again, higher on that bottom graph, graph number C, than the group that received no anticoagulation. Again, approximately an absolute risk increase of 1% or just a little less. If you look at the plot on the right side, you can see the hazard ratios plotted here, which give you a sense for benefits and risk. And essentially, mortality is reduced, stroke and systemic embolism is reduced, but bleeding is a little bit higher for patients who are on anticoagulants. But of course, this is all information that we know, and we know that the majority of our patients with AFib should be anticoagulated. The question is, what is the best anticoagulant for them? Well, this Garfield registry helped us answer that as well. Using real-world data to supplement the randomized trials, we can see that patients who received vitamin K antagonists, like warfarin, that's the blue line on the graphs, they had higher rates of all-cause mortality than the patients who received the NOAC or DOAC. I use the term DOAC, meaning direct oral anticoagulant. People will use the term NOAC, meaning non-vitamin K antagonist oral anticoagulant. Those are interchangeable. You can see that the actual difference in stroke or systemic embolism was pretty similar between the two, but here's the real kicker. The bleeding rates were lower amongst patients receiving NOACs or DOACs. So that red line on graph C there is lower than the blue line. And so that's really where we get the benefit. Similar stroke prevention, but lower risk of bleeding. And when you look at the hazard ratio plot to the right, you can see that as well. Whether it's the unadjusted or the adjusted data, lower rates of all-cause mortality, lower rates of bleeding when patients are treated with one of the direct oral anticoagulants like Apixaban, Rivaroxaban, Dabigatran, or Edoxaban. Oh, I apologize. So what's some of the new data? Where are these anticoagulants moving the field forward? Well, one area is in the diseases of coronary and peripheral artery disease. We know that we should be using anticoagulation in patients with atrial fibrillation and venous thromboembolism, but traditionally we have not used them in patients with coronary or peripheral artery disease. However, a number of years ago, the COMPASS trial asked the question whether we could safely use these drugs. So the COMPASS trial enrolled patients with stable coronary disease and or peripheral artery disease who had risk factors, things like diabetes, tobacco use, older age. And they randomized them to get one of three different treatment arms. The standard of care arm was low dose aspirin. This was a global study, so they used 100 milligrams daily. The other treatment dose, which is the one here on top, was a combination of Rivaroxaban, 2.5 milligrams twice a day, plus that baby aspirin. This is what we call the dual pathway inhibition strategy, with an exceedingly low dose of Rivaroxaban, far lower than we would typically use for AFib. They also had a Rivaroxaban only arm, but we're not really going to talk about that because it was not one that showed a significant efficacy difference. Now, I want to highlight, not only was this a study of coronary and peripheral artery disease patients, but roughly a quarter of the patients had peripheral artery disease. And that's really an area I'm going to focus in on because I think this is a place where we can potentially use these drugs. When we look at the primary outcome, which was cardiovascular death, stroke, and myocardial infarction, in patients with peripheral artery disease, you can see a striking reduction in the dual pathway inhibition group. So that's the group shown here in green. They've got very low dose Rivaroxaban plus aspirin, much lower than the group that got aspirin alone, shown here in red. In fact, there's about a 30% reduction in the hazard, so a 30% lower risk of cardiovascular death, stroke, and MI. But importantly, what you see is also on the right side of the screen, a reduction in major adverse limb events. So not only are we preventing the cardiovascular events we care about, but we're also preventing limb events, meaning amputation, meaning target revascularization or unscheduled stenting of the legs. So this seems to be a drug that could be used in patients with peripheral artery disease as well. Of course, lots of patients have PAD. Who should we be giving this to? Well, they did a look and they said, which of the patients seem to get the most benefit? And what they found is that if you had certain high-risk features, your absolute risk reduction was more than 3% over the course of almost 3 years. However, if you did not have any of those risk factors, your risk reduction was only 1%, and that was not a statistically significant difference. So it's really this group here on the left where we see the most benefit. And those are patients who had multiple vascular beds involved, meaning coronary plus peripheral artery disease, or patients with peripheral artery disease who had heart failure, who had chronic renal insufficiency, or who had diabetes. So these are the patients who seem to be sickest and therefore seem to also get the most benefit from dual pathway inhibition. Thankfully, the risk of bleeding was the similar, whether you had or did not have the high risk features. So there was no big difference there on a safety standpoint. Now, this has been followed up with another study. This was the Voyager PAD study, where they looked at patients who were getting revascularized for peripheral artery disease. So bypass surgery, stenting, things like that. Again, randomized them to get aspirin plus placebo or aspirin plus rivaroxaban. And again, we found that the group that received rivaroxaban, here shown in blue, had about a 15% reduction in acute limb ischemia, amputation, heart attack, stroke, cardiovascular death compared to the patients who got aspirin alone. So again, just following up on the same results that we saw in COMPASS, whether you're a stable peripheral artery disease patient or a patient undergoing intervention, receiving rivaroxaban plus aspirin seems to be beneficial. But now looping back to the topic that we started with, which was atrial fibrillation, what has sort of moved in that area? I think the Augustus trial was really a critical study for us here. This was a study helping us answer the question, what do we do for patients with AFib and undergoing percutaneous coronary intervention or having an acute coronary syndrome? And this was the first study that asked both questions. Should they receive a direct oral anticoagulant like Apixaban, or should they receive a vitamin K antagonist like warfarin? And then secondarily, do we need to include aspirin in addition to our anticoagulant and our P2Y12 inhibitor, or should we stick with placebo? Should we stick just with just with Apixaban and the P2Y12 inhibitor alone? And what we see here on the right side of the screen is the primary outcome. This was a safety study, so they were looking at bleeding, major or clinically relevant non-major bleeding. The take home is that when you had vitamin K antagonists and you combine that with aspirin, that's the group in purple, they had the highest rate of bleeding. Almost 20% of patients bled within just 6 months. That's like 1 in 5 patients having a bleeding event. That's exceedingly high. But if you switched vitamin K antagonists to Apixaban, and if you dropped the aspirin, so these patients are just receiving Apixaban and a P2Y12 inhibitor like clopidogrel, wow, that line in green is so much lower. That's a significant reduction in major or clinically relevant non-major bleeding. Now we're talking about 5% or 1 in 20. So we're going from almost 1 in 5 patients having bleeding on a VKA triple therapy to 1 in 20 patients having a bleeding event when you use Apixaban and you only use a P2Y12. You don't give them aspirin. So quickly just summarizing some of the updates here in anticoagulation, things have evolved rapidly in the last 10 years. We now find that the direct oral anticoagulants are the first line therapy for our most common indications, be it atrial fibrillation or venous thromboembolism. And there are some novel indications for these DOAC medications and thinking about how we combine them in different scenarios. So whether it's peripheral artery disease or patients with AFib who are undergoing coronary stenting or having a heart attack, there are new ways of thinking about how we should be managing those patients. So why don't I stop there, Professor Sobey, and why don't we open it up and do a little bit of Q&A before we move to the guidelines?
Yes. Thank you very much, Barnes, for this wonderful lecture. I think you make more modification for this lecture. I have a question from me and then question from the audience, then we go to the panelists. My questions, do you see this called a COMPASS patient? I mean, this is a COMPASS patient. This COMPASS patient only for Rivaroxaban 2.5, which is diabetes, chronic renal insufficiency, heart failure, and 2 vascular, plus 2 vascular beds. So do you think this is only for Rivaroxaban because of the COMPASS trial, or it is for NOAC or DOAC according to what you say?
Yeah, it's a really excellent question. And it is only for Rivaroxaban. And here's the reason why. Because the dose that they used, 2.5 milligrams of Rivaroxaban, is a lower dose than we have available or have tested with any of the other NOACs or DOACs. So 2.5 milligrams of Rivaroxaban is not the same thing as 2.5 milligrams of Apixaban. Many of us are used to using Apixaban 2.5 milligrams, maybe in our older patients who have renal failure and AFib or something like that. That's a higher intensity anticoagulation than 2.5 milligrams of Rivaroxaban. So for me, if I'm going to treat my COMPASS patients, a patient with peripheral artery disease who also has diabetes or also has heart failure, I'm only doing that using Rivaroxaban 2.5 milligrams twice a day, plus the low dose or baby aspirin.
The question here, and then leave it to Dr. Hisham. three questions. These questions dealing with what's known, because of the COVID. The COVID in Egypt, according to TDC in the beginning, taking Apixaban 2.5 twice or 5, and Rivaroxaban and low molecular weight for 28 days. Now we are in the era of vaccination. Can you speak about the role of anticoagulation in COVID and the role of the anticoagulation in some vaccination which is assumed to have thrombose like AstraZeneca vaccine? This is three questions and summarize for you.
Yeah, so I could do a half-hour lecture on all that if you wanted. Yeah. So here, I think that we know that COVID-19 infection is associated with thrombosis risk. And that risk seems to be concentrated in patients with moderate or severe illness, meaning patients who would be admitted to the hospital or admitted to the ICU. The data that I have seen so far would suggest that the ambulatory patient with COVID-19 is not at increased risk of thrombosis. Also, the patient who has been discharged from the hospital does not seem to be at an increased risk of thrombosis. So I'm not routinely recommending anticoagulation for those patients. The patients who I do recommend anticoagulation for are those who have moderate to severe illness, so they're admitted to the hospital. And what we've seen now is we have 4 trials that have tried to answer that question. So the first 2 were the multi-platform trials, these global trials that came together. And while they have not yet been peer-reviewed and published, they are on the preprint servers, and we've seen the press release. Essentially what they're saying is there seems to be benefit with treatment dose anticoagulation for a moderately ill patient, somebody who's maybe on the floor, they're getting oxygen, but they don't require other organ support. But once you get to that severe state where you do require vasopressors, intubation, ECMO, those advanced organ support, you sort of miss the boat. That treatment dose anticoagulation doesn't benefit you and may actually put you at some harm. That critical illness finding was further reinforced with the Inspiration trial. That was the trial published in JAMA and conducted in Iran, where again, they found there was no benefit from a moderate or an intermediate dose anticoagulation. Stick with your standard prophylactic doses in the ICU. Where things get a little interesting is we just learned this past weekend at the ACC scientific sessions that in the ACTION trial, this was a trial done in Brazil where they used Rivaroxaban for patients who what they call were moderately ill. There was no benefit from the treatment dose over those who received prophylactic anticoagulation with heparin. So that's a little bit different than the multi-platform trials. Again, we haven't seen full manuscripts for that, and so I'm not quite sure what to do. But right now at my center, the practice is everyone gets prophylactic anticoagulation. Certain patients on the floor, we may bump up to a treatment dose of anticoagulation if we're particularly concerned, but we don't do that in the ICU setting. And we don't necessarily send people home on anticoagulation. Let me stop there and see if there's questions around that before I get to the vaccine piece.
The vaccine, yeah.
Yeah, so for the vaccine, there's this new syndrome that's been termed vaccine-induced immune thrombotic thrombocytopenia, or VITT. In the US, we're referring to it as TTS, the thrombotic thrombocytopenia syndrome. Essentially, it's a form of autoimmune heparin-induced thrombocytopenia, except there's no heparin exposure. The exposure is the vaccine. It seems to be really rare. In the US, where we use the Janssen or the Johnson & Johnson vaccine, we're probably talking about 1 or 2 cases per million people vaccinated. With the AstraZeneca vaccine, it might be a little bit more common. The data that I'm seeing out of the UK would suggest it's on the order of a couple patients per million vaccinated. I believe they're up to somewhere around 250 or so cases of this. It mostly occurs after the first shot. It seems to be less common after the second shot. But again, it's a hit type phenomenon that is autoimmune driven, meaning anticoagulation would not prevent it and actually has the potential to make it worse. So I do not recommend anticoagulation for patients who are receiving any of the vaccines, be it the AstraZeneca or Johnson & Johnson. The key is if they develop thrombosis, check their CBC, check their blood counts to look for their platelets. And if that platelets are low, then you need to use a non-heparin anticoagulant while you send off that PF4, that platelet factor 4 ELISA. And that's sort of the diagnostic pathway that you go down.
Trisham.
Oh, yeah, please, thank you very much for this excellent lecture and for the comments on the COVID. But actually, we're talking about when you send patients home, you usually don't put them on anticoagulation. But actually, what we have seen that some patients that did really well, and when they went home first or second day, actually they dropped dead suddenly, and it seems like still they are at increased risk of sudden of thromboembolic phenomenon, mostly pulmonary embolism. So, is there certain patients that when you send them home, still wouldn't let them quit their anticoagulation, or what is your policy in this point?
Yeah, it's a really good question, and I should put a little clarification on my recommendation. The reason that we are not sending people home from the hospital on anticoagulation is because of the 4 studies I know of that have looked at this, and they're all retrospective. 3 of the 4 have shown no increased risk of thrombosis compared to patients without COVID or in the year before COVID. The one exception is there is one study that came out suggesting a slightly higher rate of post-hospital thrombosis. I think there is currently a randomized trial that's ongoing trying to answer that question. Clearly, the data we get from that is going to be much better, and that will really guide our treatment. But we have data from before COVID saying that some people are at risk of hospital-associated thrombosis, and those patients benefit when you give them whether it's Apixaban, Rivaroxaban, or Betrixaban, some form of an anticoagulant. And so if in your experience you're seeing certain patients at higher risk that you want to give them that short course, maybe 35 days of Rivaroxaban, similar to what was done in the Magellan study or the Mariner study, I think that's reasonable. I just don't know that we have the published data to say that that needs to be done for every patient with COVID. So far, the data would suggest that the rates are not that high, but it's not perfect data.
If I add one more question, would you recommend something like D-dimer at time of discharge as a sort of guide to which patient should we continue anticoagulation, or what level of D-dimer, or it is not of value at all?
Yeah, that's a great question too. Again, I don't think we have good data in COVID patients, but when you look at some of the other data, meaning the Mariner and Magellan studies, the Apex studies, D-dimer was a significant predictor of who developed post-hospital thrombosis. And so I think that would be one of the factors that you could incorporate if they still have an elevated D-dimer at the time of discharge. Not when they were admitted 5, 6, 7 days ago, but you're getting ready to discharge, that D-dimer is still elevated. That might sway me a little more to saying, yeah, let's go ahead and give you a short course of anticoagulation. I think that would be a reasonable strategy until we get the randomized trial data.
Thank you, Walid. Okay.
Thank you, Dr. Bernes, for such elegant presentation. My question regarding different oral anticoagulants. And in your presentation, you showed us the pattern over the past 10 years of different anticoagulants in US. And you showed us that we have a marked decline in prescription of dabigatran, also in prescription of Rivaroxaban, and on the other hand, the prescription of Apixaban is increasing over time. How do you explain this?
Yeah, it's a really interesting process to follow. I think a couple things have happened. So dabigatran, of course, was the first of these direct oral anticoagulants that was approved in the US. And there was some real excitement when it was used. But I think it suffered from 2 main challenges. Because it was the first to be used, some people may have used it in inappropriate situations, or if somebody had a bleeding event or a side effect, it sort of made people scared and said, wait, I'm going to go back and do what I've always done, which is use warfarin. So there was a little bit of fear when it was first used. But more importantly, it also came out that it caused a lot of GI upset, some really significant nausea and abdominal pain. And so as soon as Rivaroxaban became available and did not have that same risk, I think many people said, let's switch over to that one. And because Rivaroxaban was the second drug, there was a little bit more comfort in people using it. So it really took off. I think the switch to Apixaban has been because the clinical trial data would suggest that it has a very favorable bleeding profile. And so it's, and some would suggest it might have lower bleeding risk than Rivaroxaban. I don't know that for sure. It's never been tested head to head. There have been some observational studies that have looked at it and suggested perhaps it does have lower risks of bleeding. But I think many clinicians have started to think, hey, that's a drug I can use, low risk of bleeding. It's easy to prescribe. I don't have to calculate a creatinine clearance. I can just look at your creatinine, your age, your weight for AFib, for instance. And so that's really led this sort of general use of that drug for many patients.
Do you have data if this pattern of prescription is worldwide or just a USA pattern? Because at least in Egypt, both are the same, Rivaroxaban or Apixaban. We don't have this discrimination in favor of Apixaban.
Yeah, I personally don't have that differentiation on me, although I do know that there is some data that's out there. I would say that in general, those seem to be two of the most commonly used drugs worldwide, with a few exceptions. There are areas of Asia where Edoxaban is very commonly used because it was widely developed and marketed there. There are parts of the world where either Rivaroxaban or Apixaban are not available, and so they only can use one, or Dabigatran is the only one approved, and so that's used more commonly. So there's certainly a lot of global variation.
Can I add one more question, please? Actually, for new oral anticoagulants now, we have almost most of the indications are okay, except for prosthetic mitral valve and those with triple positive antiphospholipid syndrome, which the data were disappointing with this. But what about patients with post-myocardial infarction, left ventricular thrombus? Are you using new oral anticoagulants or still with warfarin?
This is an area of really interesting discussion. You know, I think you bring this up because there was a paper published, I believe it was in JAMA Cardiology last year, suggesting that maybe the direct oral anticoagulants were not as effective as warfarin in patients who had left ventricular thrombus. My personal read of that data was the analysis had some important flaws. And so I'm not sure that I would hang my hat on that data alone. Furthermore, there was another analysis that came out shortly thereafter, and I don't recall exactly what journal, but it was not quite as high a profile journal, showing the exact opposite, that maybe the direct oral anticoagulants had fewer stroke events and fewer recurrent events, and that the patients had better thrombus resolution when they used a direct oral anticoagulant. So my personal practice is that I use them regularly. I don't have any concern. I let patients know that the data is not solidly behind one treatment or another, and technically it's off-label. The FDA has not, labeled the drugs for left ventricular thrombus, but I would say about 2/3 of my patients with LV thrombus would prefer to be on a direct oral anticoagulant just because it's easier. About 1/3 of them, because of renal issues or cost issues or whatever, we end up using vitamin K antagonists. And they do quite well as well. But I don't have any concern using them in that clinical scenario.
Dr. Barnes, these some patients who have ectatic vessels, slow flow, recurrent myocardial infarctions, and we do angiogram, and the patient don't stent them, but they still have. So these a study, I think, in France regarding the use of Rivaroxaban or Apixaban in such patient, adding with aspirin. In the past, we tried warfarin and then DAPT, and finally we don't have evidence of which drug of the NOAC or DOAC to be used. What do you think? Do you have any data or any studies in the US on Europe?
Yeah, so there have been two studies that I think sort of relate to that clinical question. So the first would be the COMPASS study. Remember that about 3/4 of the patients enrolled in that study had coronary disease. Now, granted, that was stable coronary disease, not an acute coronary syndrome. But again, the idea that a patient who's enrolled because of atherosclerosis would benefit from a very low dose of Rivaroxaban, it's sort of fit. And the overall trial results there were positive. That study actually built off of a prior study, and I'm blanking on the name at the moment, but that study looked at the use of very low dose Rivaroxaban in addition to dual antiplatelet therapy in acute coronary syndrome. And while it did reduce some of the cardiovascular events, it led to an increased risk of bleeding. And so it never got FDA approval. And in the United States, our clinicians didn't really adopt the use of that strategy. But there certainly is a theory behind why it could be beneficial. We know that atherosclerosis leads to thrombosis through multiple mechanisms, and a very low dose of Rivaroxaban certainly has a role to play there. And so while it's not a common practice in the US, there is some data. And if I can think of the name of the trial, I'll bring it up, or when I'm done, I might look it up real quick and send it to you.
Okay, thank you. Now, thank you very much for the, Dr. Walid, you need any question?
Please.
Okay, go.
We have two factors that are taken into consideration in prescription of Edoxaban and Apixaban. These are age above 80 and body weight below 60 kilograms. But these two factors are not taken into consideration when prescribing Rivaroxaban, just kidney function. Do you have an explanation for that? And do you have the courage to prescribe Rivaroxaban in full dose in 80-year-old below 60 kilograms? Thank you.
Yeah, it's a great question. So the explanation for why is not very scientific. It's just that's the way the investigators chose to set it up in the clinical trials. And because of that, therefore, that's the way the FDA labeled the package. The underlying piece is when you calculate the creatinine clearance, it takes into account age and body weight. So the factors that go into the Apixaban dosing, serum creatinine, age, and body weight, also factor into Rivaroxaban dosing. It's just that you put them into a formula, the Cockcroft-Gault formula, and you calculate a creatinine clearance. So in reality, they both are adjusting for the same factors. They're just doing it in a different way. So I have many patients who are of older age, who have really good creatinine clearance, who do get treatment dose Rivaroxaban. However, because the threshold for Rivaroxaban is higher, it's a creatinine clearance of 50. Even an older patient, let's say an 85-year-old woman who's maybe pretty low body weight, doesn't have a lot of muscle mass, even if she has a creatinine of 1.0, 1.1, her creatinine clearance might be below 50 and therefore would qualify for a reduced dose anyway. So I always work with a pharmacist to calculate the Cockcroft-Gault creatinine clearance and then use that to guide my Rivaroxaban dosing.
Last question, Dr. Shihab Atrebi. Dr. Shihab.
I wanted to ask about the patients with protein C and S deficiency. Do you recommend long-term oral anticoagulation for these patients, or just prophylactic if they will have any risk like flying or climbing mountains?
Yeah, it's an interesting question. So what I would say is true deficiency of protein C or protein S is thankfully pretty rare. We tend to overdiagnose it because the way we test for it in the setting of an acute clot or in somebody who's taking a vitamin K antagonist will often lead to an inappropriately low test. And so it really needs to be tested and diagnosed carefully. I find about half or more of the patients who are referred to me for protein C or protein S deficiency, when I retest them, they actually don't have deficiency. It was just testing done at the wrong time. But to get to your question, assuming the patient has legitimate deficiency in protein C or protein S, usually I only know about that because they had a clot, in which case they need to be anticoagulated long-term anyway, and I'm perfectly comfortable using a direct oral anticoagulant or a vitamin K antagonist. I have found very few patients who were sent to me for true protein C or protein S deficiency without a history of thrombosis, because we just don't test for it that often. And so I'm not sure that I would anticoagulate somebody who has a deficiency but has never had a clot. They haven't proven that they've had a clot. I might consider some sort of prophylaxis, maybe an aspirin, but but I honestly haven't encountered that situation, so I couldn't give you a lot of guidance there.
I think we have a lot of questions, but we can make it up the second talk. Now the guidelines, the European Society ETC guidelines. Let's go.
Okay, so we're going to talk now about atrial fibrillation guidelines, and I'm going to compare and contrast the American College of Cardiology guidelines with those that were recently released from the European Society of Cardiology. So you can see here, these are the two different guidelines. In 2019, the North American guidelines from the American Heart Association and the American College of Cardiology. And then in 2020, we had the European Society of Cardiology. And of course, these are huge documents. They cover a lot of material. I'm going to try and focus on 4 key areas. First is who with atrial fibrillation should be receiving anticoagulation. And once we've decided to give an anticoagulant, which one should we give? I'm going to talk a little bit about how do we manage bleeding and which patients should we be thinking about mechanical stroke prevention in. Those are, I think, some of the interesting areas. And then I'll finish up with a quick summary of the ESC guidelines, some of the new or changed topic areas. So let's start out with reviewing who should get anticoagulation. Well, really, there's a lot of similarity between these two. They focus primarily on estimating stroke risk and doing that using the CHADS-VASc score. And they agree that if a patient has no risk factors other than sex, meaning a CHADS-VASc score of 0 for men or 1 for women, no anticoagulation is recommended. The risk of stroke is just too low. If they have 1 non-sex related risk factor, so that's a CHADS-VASc score of 1 for men or 2 for women, then you can consider anticoagulation, but it's not mandatory. This is a great opportunity for shared decision-making. However, once you have 2 or more risk factors for stroke other than sex, so a CHADS-VASc score of 2 in men or 3 in women, then the guidelines are pretty clear. All of those patients should receive oral anticoagulant therapy because their risk of stroke is sufficiently high that they would warrant benefit from anticoagulation. Now, there's 2 other areas that they focus on, and they have to do with patients who are getting cardioverted for their atrial fibrillation. And there's a subtle difference between the 2 guidelines. So for patients who have had atrial fibrillation and we're confident that the duration of atrial fibrillation is less than 48 hours, the ACC, AHA, and ESC guidelines agree you do not need to anticoagulate them before you cardiovert. That shorter duration, the risk of stroke is quite low. You can just cardiovert them right away. However, the difference comes in the post-cardioversion piece. The North American guidelines say give 4 weeks of anticoagulation if they're at risk for stroke, meaning a CHADS-VASc score of 2 or greater in men, 3 or greater in women. Whereas the European Society of Cardiology says 4 weeks for your low risk and long-term for everyone else. So the ESC guidelines saying, yeah, cardioversion is probably not curative of AFib, so presume they're going to go back in and out, anticoagulate them. Similarly, we see the same thing when they recommend cardioversion for patients who have been in atrial fibrillation for more than 48 hours. In this case, everyone suggests 3 weeks of anticoagulation or imaging, such as a CT scan or a transesophageal echo. And in this case, again, it's 4 weeks in the North American guidelines, and it's 4 weeks or long-term based on the CHADS-VASc score in the European guidelines. Now, once you've decided that you're going to anticoagulate, what do you give? Well, they both agree. Direct oral anticoagulants, meaning Apixaban, Dabigatran, Edoxaban, and Rivaroxaban, they are now first-line preferred agents over a vitamin K antagonist like warfarin. Warfarin, vitamin K antagonists are still acceptable, but we should start by seeing if the patient can tolerate and take a direct oral anticoagulant. There are 2 important exceptions to that rule. The first is anyone with a mitral valve, anyone with a mechanical valve absolutely should not get a direct oral anticoagulant. And that's because of the study where Dabigatran was given to patients with mechanical valve and had increased valve thrombosis risk. So we do not use these drugs in any patient with a mechanical valve. It is okay to use it in a bioprosthetic valve. So I want to make that important distinction. The second group where the guidelines would say warfarin is still first line are in patients with moderate to severe mitral stenosis. And it's not because there's a safety concern with these drugs, it's just because they've always been excluded from the guidelines and their thrombosis risk is very high. And so we've traditionally used warfarin, and we haven't really yet tested that group using a direct oral anticoagulant. But as you can see, this definition for when patients have valvular AFib has really narrowed to just these two indications. Everything else, aortic valve disease, mitral regurgitation, bioprosthetic valve replacements, all of those patients are okay and actually recommended now to get a direct oral anticoagulant if they have atrial fibrillation. Now, how do you prescribe them? Here, I put up the prescribing instructions according to the European Society of Cardiology. And you'll see for dabigatran, the standard dose is 150 milligrams twice a day. Now, in many parts of the world, there is a 110 milligram dose. That's not available in the US. We only have a 75 milligram dose. But if you're if you have access to this 110 milligram dose, the European guidelines would suggest that that's a good option for older patients, those who are using an important drug-drug interaction like verapamil, or patients who you deem to be at increased risk of bleeding. For Rivaroxaban, the standard dose is 20 milligrams once a day. You can reduce that to 15 milligrams once a day if their creatinine clearance, again, a Cockcroft-Gault creatinine clearance, is anywhere between 15 and 49. And it's generally not recommended for patients with creatinine clearance less than 15. For Apixaban, the standard dosing is 5 milligrams twice a day, reduced to 2.5 milligrams twice a day based on age, body weight, and serum creatinine. If you have 2 or more of those criteria, that's when you reduce the dose. And Edoxaban is 60 milligrams once a day. You can reduce that to 30 milligrams once a day, or even 15 milligrams once a day based on creatinine clearance, body weight, and certain other drug-drug interactions. Now, what about bleeding? What should you do if you have bleeding associated with an oral anticoagulant? Well, obviously, the first thing you do is you control the bleeding manually if possible. So if it's skin-related bleeding or something, let's hold pressure. Let's try and get that under control. Clearly, we need to assess hemodynamics. If this patient is in shock, we need to treat them much more aggressively than the person who just has a nosebleed that won't stop. And then you want to ask, what anticoagulant are they on and how recently have they taken it? If their last dose of an anticoagulant was a week ago, then it may not be that relevant to their bleeding. But if they just took it 4 hours ago, it certainly could influence. And then, of course, the last thing we ask about is severity of bleeding. Is this a minor bleed? I'm thinking a nosebleed. I'm thinking a skin bleed, something like that. Well, then you either just delay your next dose while you're managing it, maybe 1 dose, maybe 2 doses if needed, until things are stabilized. If this is a moderate to severe bleed, somebody admitted to the hospital, but they're not bleeding into a critical organ like the brain, they don't have evidence of shock, this is a time where fluid replacement, maybe blood transfusions needed. Clearly try and treat the bleeding cause. So if it's a GI bleed, endoscopy would be important. And then depending on the severity, you may need to reverse the drug. So vitamin K antagonists, maybe you give some vitamin K. For the direct oral anticoagulants, this would be a chance to maybe think about charcoal if you need to get a recently ingested drug out. But the severe or life-threatening bleeds, those are the ones where we start to get really aggressive. Now I'm talking about a bleed into the brain or a person who's bleeding and is in shock, hemorrhagic shock. This is where we reverse it. So for vitamin K antagonists, we're talking about PCCs, prothrombin complex concentrates, or FFP, fresh frozen plasma. And then think about replacing platelets if needed. For a patient on a direct oral anticoagulant, this is where we might consider a specific reversal agent if it's available. And I put those over on the side. For dabigatran, the specific reversal agent is idarucizumab. For Rivaroxaban and Apixaban, the specific reversal agent is andexanet alpha. But if those aren't available, that's okay. You can still use prothrombin complex concentrates. And the retrospective data would suggest they're probably highly effective. Of course, if you need to replace platelets, you can do that as well. Now, what about the patients for whom anticoagulation is not a good idea, but they're still at risk for stroke related to atrial fibrillation? Well, this is where left atrial appendage becomes a great option. For surgical occlusion of the left atrial appendage, this should be considered during cardiac surgery. This, of course, were guidelines from 2020. We actually just got some new data from the left atrial appendage occlusion 3 study, or the LAOS 3 study at ACC this past weekend, showing that it is an effective strategy for reducing stroke in patients undergoing cardiac surgery. But of course, percutaneous left atrial appendage occlusion is the one that really, I think, is growing. This is use of things like the Watchman device or others. And this could be considered if a patient has a contraindication to long-term anticoagulation. Both guidelines agree on this. The key is they usually require a short course of anticoagulation. So if you look at the table here, a patient getting a Watchman who is at low risk for short-term bleeding, not only are they going to get aspirin therapy long-term, but they're probably going to get 6 weeks of an oral anticoagulant like warfarin. Now, sometimes you can skip the anticoagulant and just do aspirin plus clopidogrel at a patient who's at higher risk for short-term bleeding. But again, there's some concern that you're going to need to at least be on an aspirin therapy long-term to make sure that you don't have any device-related complications. Now, the ESC guideline put together this nice, I think, framework for how we should think about managing patients with atrial fibrillation. They talk about the 4 S's. So the first one being assess stroke risk and determine whether or not it needs to be treated. The second is assess the symptom severity. Is this somebody who's asymptomatic or mildly symptomatic, or is this somebody who's having severe disabling symptoms from their atrial fibrillation? The overall treatment strategy is going to differ. We need to think about the severity of AFib burden. Are these patients who are having very short courses, just a couple minutes, that's being picked up on say a pacemaker or a defibrillator? Or are these patients who are having hours and days of atrial fibrillation? And then, of course, what's the substrate? Why are they getting this? And that's an important consideration. Does this person have underlying structural heart disease? Do they have obstructive sleep apnea? Are there other comorbidities that if we helped to manage them, we could lower the patient's risk of not just AFib, but also complications like stroke? Now, the ESC did make, I think, one really important update, and that is around the language we use to describe atrial fibrillation. They talk about using terms like paroxysmal and persistent and permanent, and those are terms that I think all of us traditionally have used quite a bit. But they're now suggesting we get rid of a couple terms, and I want to point you to, so I'll just quickly review this slide. The ESC recommended that we get rid of this term valvular atrial fibrillation and instead describe atrial fibrillation associated with whatever, mechanical valve or mitral stenosis, and be more specific, because we've narrowed the specific valve diseases in which the direct oral anticoagulants can and cannot be used. I'm going to finish up with a couple key elements here, and these are the new or changed recommendations that I think are important in the ESC guidelines. So first is they actually recommend we reassess stroke and bleeding risk periodically, because not every patient needs to be on their anticoagulant long term. And so sometimes it's helpful to reassess and determine, should we continue anticoagulation or has the bleeding risk?
يا جماعة. Close. Yes, go ahead. So, okay.
Okay. The next thing is that while they talk about certain risk scores, like the Hasblood score for bleeding risk, they say that should not be used to decide who does and does not get anticoagulation. You might use it to figure out what factors are reversible or modifiable, so reducing alcohol use, managing hypertension, but we shouldn't say that anyone with a Hasblood score above 3 doesn't get anticoagulation. That doesn't make sense. So it's not something that should really guide anticoagulant treatment decision-making. They talk about how the pattern of AFib, paroxysmal, persistent, really does not matter when it comes to anticoagulation. If you have AFib and there's enough burden, you're at risk for stroke, and that's how you should think about who gets anticoagulation therapy. And then, of course, we talked about the importance of cardioversion. They also say that anticoagulation for 3 weeks is recommended prior to catheter ablation procedures. and that we should not interrupt that anticoagulation for the procedure. That should just continue throughout. Now, we can continue for at least 2 months, and then beyond that, really the decision around continued anticoagulation should be based on the stroke risk, not the success of the procedure. So even patients who have a successful ablation procedure really may still have recurrent AFib, therefore they're at risk for stroke, and therefore continuing anticoagulation is recommended. And then they also make an interesting comment that if a patient's treated with a vitamin K antagonist, but they're not well managed, so their time in the therapeutic range is less than 70%, those are patients we should think about switching over to a direct oral anticoagulant, see if we can get more consistent stroke prevention. So in summary, when we look at the ESC and the ACC guidelines, anticoagulation is really recommended for everyone at high risk for stroke. Consider it for that intermediate risk group, avoid in the low risk group. And remember that the CHA2DS2-VASc score does differ slightly based on sex. DOACs are now first-line therapy for almost all patients with atrial fibrillation, the exceptions being mechanical valves and moderate to severe mitral stenosis. Make sure that you have protocols in your office, in your hospital for managing bleeding, and break it down by minor bleeding, moderate to severe bleeding, and life-threatening bleeding, because the management strategies are different. And lastly, you can consider left atrial appendage occlusion if a patient's undergoing cardiac surgery or if they have a contraindication to long-term anticoagulation therapy. So I'll go ahead and stop there, and hopefully we can do some more Q&A.
Yeah, I think thank you very much for these wonderful lectures. You know, there's some changes actually depending. I think that I like the slides of the 4 wheels. The 4 wheels, maybe this explain that it's something changed in the guideline. Also, the second slide, which is that there is no valvular or non-valvular AF anymore, and no chronic AF, no low intervention. We studied 30 years ago. It's now changing. Do you think this change in the guideline will influence the treatment and the application of the drugs, or coming because of we have other drugs rather than warfarin? Because, you know, this is only 1-2 years. So how can you, as an expert, putting the guideline, found this is useful for the management or stay on therapy for NOAC or QUAC?
Yeah, it's a really good question. And like all guidelines, I think there will be changes in practice, but they'll be slow. The challenge we have in the United States is, of course, the package label for these drugs still uses the term non-valvular atrial fibrillation. And that's because the clinical trials use that for their inclusion and exclusion criteria. And so I do think it's going to take time for more data to come out, perhaps even other trials to occur that sort of broaden the definition and the inclusion so that the package label can eventually change. However, I find that when I talk to my colleagues, because we now have the guidelines to hang our hats on, people are using these drugs more often in patients with, say, aortic stenosis or mitral regurgitation. So I do think we're seeing some change. It won't be overnight. It's going to take time, but I'm optimistic we'll continue to see more patients get the potential to receive Apixaban, Rivaroxaban, and the others, which really simplifies their therapy.
I have a question from me, but this is found also in the chat. If a patient develops atrial fibrillation in post-CABG patient, or which is very common, 30% of the patient develop, are you going to cardiovert them amiodarone, or are you going to risk stratify this patient and give long-term anticoagulation? The same for the PCI. Sometimes the patient going the PCI develop atrial fibrillation during the procedures or after the procedures, and then revert to sinus rhythm. Are these candidates of patient post-PCI and post-CABG just transient atrial fibrillation is an indication of triple, or you go for the triple and removing aspirin after 1 week and go for a Gusto, Pioneer, or a dual trial? How can you explain this kind of patient? Because it's temporary AF.
Yeah, we see that a lot. And I'll tell you, I think this is a perfect area for another clinical trial to be conducted. the practice in the US is varied when it comes to cardiac surgery, but most of the time, people do not get anticoagulation after cardiac surgery. They're usually given amiodarone as long as the AFib goes away, or maybe they're just given 6 or 8 weeks of anticoagulation and then it's stopped as long as an event monitor shows no recurrence. I don't know if that's the right answer or the wrong answer. We really need a clinical trial to help us answer that. When it comes to PCI, if the AFib is occurring during the procedure, the patient's on the table, we tend to not treat that. But if the AFib is occurring afterwards, maybe they've gone back to the hospital ward and then they develop AFib, those are patients in whom we tend to treat with anticoagulants. Because again, the irritation of the procedure that happens with a CABG that we think sets off AFib is much higher than what happens during a PCI. And so AFib that's happening after PCI, I tend to think of as being more of real AFib and not sort of this irritation from an open heart surgery.
Hisham. Yeah. You are on mute.
You might be on mute.
For patients with CABG, some authorities are concerned about the issue of atrial stunning for some time, for 4 weeks or something. Would that make still the use of anticoagulation, as you said, for 4 to 6 weeks would be an appropriate approach in these patients?
Yeah, that's a common strategy I see my cardiac surgeons use. So if they're seeing, AFib that's more than a couple minutes after surgery, lasting hours or coming back and forth, they'll usually start them on amiodarone and put them on, say, 6 weeks of anticoagulation or 8 weeks of anticoagulation. And then they'll often put an event monitor on, maybe a 7 or 14-day event monitor. If there's no AFib on the event monitor, the surgeons often will stop the anticoagulant. Again, I don't know if that's the right answer. I think a randomized trial would really help us figure that out. Of course, it would require a lot of patience, and so there would have to be significant financial investment.
Thank
Thank you again, Bernice. We all know that female gender is included in CHATS VASC score. It is not a risk factor, it is just a risk enhancer. And despite that, it is taken into the algorithm of decision making. I wonder why it is still in the algorithm, despite having no impact on decision at all. Even a female gender without other risk factors is not indicated for anticoagulation. And in every step of recommendations, we mention males for 1, females for 2, males for, and so on. Why it is still included in the algorithm?
Yeah, I agree with you, and I think there's 2 reasons for it. When the CHADS VASC score was initially developed, that particular feature was not discussed in detail in the paper. It's listed there, but it was not a main sort of call out, and so I think it was just missed. And if you look at some of the earlier guidelines, they don't distinguish between men and women. It wasn't until later iterations that people started saying, wait a second, female sex is an additive risk factor, not a risk factor on its own. I'll tell you, it is one of the things that I find most frustrating when I put together a presentation or write a paper. It's so confusing to have to differentiate it. I wish we could come up with a new acronym that just dropped female sex characteristic altogether, but CHADS-VA doesn't sound very good. So for now, I think we're stuck with it until somebody comes up with a better risk score.
Regarding the valves, I have 2 questions for the valves. One regarding why not in mitral stenosis and don't do it in mitral regurg, because it is depending on the left atrium. If the mitral regurg left atrium is huge, it's not the size. The same for the mitral stenosis, so it's not used to have NOAC only warfarin. The second, in bioprosthetic and mechanical. In bioprosthetic, it's even we give anticoagulation for 3 months, at the surgeon I recommend, and then we don't give in bioprosthetic more than 3 months. So why it is not effective in mechanical and effective in bioprosthetic valve? Because of the metal, you mean, or the liability of thrombose? Because it can occur in biprothetic. Thrombosis can occur in biprothetic. So I can't understand. Also, there is a trial called River, which favor biprothetic. A trial called Invictus is coming now, but you don't have an actual results. Maybe Salim Youssef regarding mitral stenosis. How can you find this error? Because still a problem. We are afraid to use any NOAC in such patients.
Yeah. So many excellent questions there. So I'll try and go through a few of them. Why mitral stenosis and not mitral regurgitation? And it's really a historical piece. When we talk about moderate to severe mitral stenosis, what we're really worried about is rheumatic mitral stenosis, because when you look at the data from the 1970s and 1980s, we found that that group of patients was at strikingly high risk for a stroke. So when we did the first sort of randomized trials on should you get anticoagulation or not in AFib, those patients were excluded because we already knew they needed to be anticoagulated. That set the floor, and every study that has come after that has said, well, we have to then use that same group of patients. So to me, it's not that Apixaban or Rivaroxaban wouldn't work. It's just that we've constantly excluded them from every single randomized trial. I mean, these are drugs that prevent thrombosis. So there's nothing special about mitral stenosis that means the mechanism for thrombosis is different. The level of risk is higher, but I think in theory they would work. It's just they've never really been tested prospectively. For the question about the valve replacements, there's been a lot of speculation as to why dabigatran did not do well with mechanical valves. And the thought is it probably has to do with the contact pathway as an activation mechanism for thrombosis. And when you have the mechanical metal that's in the body for a mechanical valve, that's a really high contact pathway activator. That's not the same when you get a bioprosthetic valve. You don't get quite as much activation of the contact pathway. So people think that might be why these mechanical valves are more thrombogenic. There have been some discussions about using factor Xa inhibitors in mechanical mitral valve. This is obviously only in a very controlled exploratory setting, not for routine clinical practice. But I will say that I think we now have a number of studies showing us whether it's a surgical bioprosthetic valve or a transcatheter bioprosthetic valve, that it is safe to use a direct oral anticoagulant when there's another indication for anticoagulation, such as AFib. What we shouldn't do is take a bioprosthetic valve like a TAVR and give anticoagulation just because. That's not a good situation. But if you have AFib and you're getting a TAVR valve or you're getting a bioprosthetic valve, I routinely will use Rivaroxaban or Apixaban, and I don't have any concern there.
Okay. Dr. Shihab Atrebi or Dr. Sharif Wagdi, do you have any questions?
Can I have that one?
Okay, to read. Yeah.
Dr. Bernes, a patient coming with stroke or TIA, and he is in sinus rhythm. How would you manage such patient looking for atrial fibrillation?
Yeah, so when I see patients who have a new stroke, they all get an echocardiogram. Let's look to see if there's a cardiac source of embolism. And of course, they're all put on a cardiac monitor while they're in the hospital. If I find evidence of thrombosis on the echo, if I find AFib on the monitor, easy. Those are patients who are going to get anticoagulation. But I think what you're talking about is the person whose echo looks normal and there's no AFib on those 48 or 72 hours of telemetry. I routinely recommend that those patients go home with at least 4 weeks of an event monitor to screen for AFib. And if I'm concerned, if they have multiple risk factors, I'll sometimes repeat that event monitor because it's very common that they have paroxysmal AFib that we just didn't pick up. I won't anticoagulate them until I see the AFib, however.
Okay, thank you very much, Bernes. Now we shift to the cases. You be with us for discussion. We'll change I start by Dr. Sharif Wagdi, Professor of Cardiology in Alexandria University. Sharif is going to speak. Give us a case, atrial fibrillation with heart failure. How do you manage? This is a very interesting case, Sharif, as usual, I know.
Okay, after this elegant presentation by Professor Barnes regarding the guidelines and the oral anticoagulation, we'll shift to some cases, different cases. I will be presenting a case of atrial fibrillation with heart failure. So our patient is a 76 years old male patient. He's coming complaining of worsening of dyspnea, bilateral lower limb edema, and headache. He's passed
علي صوتك يا دكتور شوان فضل.
He had type 2 diabetes. He's on oral hypoglycemic since 10 years, and he's also having a long history of hypertension since 20 years. His current medication, he is only taking his anti-diabetic medication, metformin and gliclazide for the diabetes, and bisoprolol 5 milligram for his hypertension. Upon examination, clearly he has an uncontrolled blood pressure. His blood pressure was 175 over 105. He is overweight. His body mass index is 35. His heart rate is 76 beats minutes irregularity, atrial fibrillation. He has bilateral basal crepitation and a pansystolic murmur over the apex and tricuspid area, as well as a bilateral lower limb edema. His lab investigations are normal kidney function and GFR, normal sodium and potassium, with uncontrolled diabetic contagion. As we can see, his glycated hemoglobin is 7.6. This is the electrocardiogram of the patient. As we can see, there is some voltage criteria denoting left ventricular dilatation and hypertrophy, as well as controlled atrial fibrillation, because the patient is taking the bisoprolol for the hypertension. That's why he didn't had a rapid atrial fibrillation, and most probably his atrial fibrillation is a long-standing undiagnosed atrial fibrillation. His chest X-ray again showing a diffuse cardiomegaly with some bilateral congestion and some basal effusions, bilateral. His echocardiography showed the dilated left ventricle with a global hypokinesia with an ejection fraction of 30%, and the mitral and the tricuspid regurgitation, as we can anticipate by atrial dilatation, as well as the regurgitation, denoting that this patient is suffering from a long-term atrial fibrillation, not a recent one, and was undiagnosed due to the low heart rate from the use of bisoprolol for the hypertension. So regarding the diagnosis of our patient, he is a patient with heart failure, reduced ejection fraction, HFrEF. He has a persistent atrial fibrillation. He is hypertensive, and he had type 2 diabetes, and that's the main findings or the main diagnostic points in our patient. So we have to treat the heart failure, and we have to treat the blood pressure, and we have to rate control and anticoagulation for the atrial fibrillation, as well as controlling his diabetic condition. Regarding HFrEF treatment, we are not going into detail, but we all are famous, and we know the recent guidelines for HFrEF treatment. So we have to put ACE or ARB or ARNI if the patient can afford or available. It's a class 1 indication. Besides the beta blocker, the cardioselective beta blocker, and the mineralocorticoid antagonist. And this is the main treatment for the HFrEF treatment. What about the atrial fibrillation in our patient? So regarding the atrial fibrillation, as Professor Barnes said, we have several items to fulfill. First, we have to use, are we going to use a strategy for rate control or rhythm control? The use of anticoagulation before prescribing the anticoagulation, we should know the embolic risk with the Schatz-Vass score, as well as the bleeding risk from of our patient with the Has-Platt score. So according to the last guidelines, our patient has a HFrEF patient. So if you are using the strategy for rate control, the beta blocker are the first line treatment for controlling atrial fibrillation in patients with heart failure and reduced ejection fraction. And we should know that our target, when to know that we are having an optimal rate control, if we are having a resting heart rate less than 110 beats per minute. So if we fail with the beta blocker, then we have the second line treatment is the digoxin or the amiodarone. If we fail with this dual combination, then we can shift to the third line treatment is the triple combination of the beta blocker, digoxin, and amiodarone. If the patient cannot tolerate this triple combination, then we can move for evaluation for CRTP or CRTD with pacemaker implantation and atrioventricular implantation. And these are the recommendation according to the last ESC guidelines. So beta blocker and or digoxin are recommended for heart rate control in AF patient with ejection fraction less than 40%. This is a class 1 indication. Then we have a combination therapy if you fail with one drug. This is a class 2A indication. And don't forget that our goal, when to say it's optimal, is to have a resting heart rate of less than 110 over beat per minute. And if you fail with the medication, the role of atrioventricular nodal ablation with pacemaker insertion is still a place when we fail with the medical treatment. And again, this is a class 2A indication. So after rate control, we must know the bleeding and the stroke rates. So as elegantly presented before by Professor Barnes, we have to know the SHADS-VASc score. It's a score having many points. We have the heart failure is a 1 point, hypertension, age above 75, diabetes and stroke, vascular disease and age below 75, and having female as a risk factor. And the maximum score is 9. So our patient is having a HFrEF. This is 1 point. He is having hypertension. This is 1 point. He is diabetic, 1 point, and his age is 76. This gives him 2 points. So the total SHADS-VASc score of our patient is 5, which makes him a high-risk patient for thromboembolic events. And that's why we should start a potent and proper anticoagulation of the patient. What about his bleeding risk? When we look for the Hasblad score again, we have the uncontrolled hypertension, we have the abnormal renal or hepatic function, we have the history of stroke, bleeding predisposition, labile INR if he used the vitamin K before, elderly, and drugs or alcohol induced. And again, this score is having a maximum score of 9. What about our patient? Our patient has only uncontrolled hypertension. This is 1 point, and age of 76, 1 point. So the total Hasblad score for our patient is 2. So our patient has a high risk for thromboembolic event, as we had his SHADS-VASc is 5, and the bleeding risk is not that much. That the Hasblad is 2. So we should go for full proper anticoagulation to prevent him from the thromboembolic event. What type of anticoagulation we are going to use, as we just previously presented. So only patient with prosthetic valve or mitral stenosis moderate to severe are candidate for vitamin K. If not, so our patient is candidate for oral anticoagulation. And of course, if the SHADS-VASc score is above 2 for male or above 3 for female, oral anticoagulation, especially for with the NOAC or class 1 indication with level of evidence A. And these are the recommendations that the preferred treatment for patient with non-valvular atrial fibrillation is the NOAC, and patient with having risk score more than 2 for male and more than 3 for female are using should be anticoagulation. And again, this is a class 1 indication with level of evidence A. And for risk assessment, if the bleeding risk is not high, so we can use the as presented before, the left atrial appendage closure. This may be a chance for patient having a high bleeding risk. What about the role for rhythm control and the catheter ablation for symptomatic patient with atrial fibrillation? Regarding our specific address in our case, our patient with heart failure and reduced ejection fraction. So when we look for patient with HFrEF and atrial fibrillation, we should consider the patient choice. So if the patient is accepting and choosing the choice of catheter ablation, in this indication, this is a class 1 indication with level of evidence C, and we should perform catheter ablation for this patient. If the patient prefers antiarrhythmic drugs and he is not needing to or accepting to do the catheter ablation, so we use the antiarrhythmic drugs, and in this condition, we prefer the amiodarone for a strategy of rhythm control. If the drug therapy fails, then we perform catheter ablation. In this indication, it's a class 2A indication, not a class 1. And if it succeeds with the oral antiarrhythmic drug, so we continue with the antiarrhythmic drug for the strategy of rhythm control in patients with atrial fibrillation and reduced ejection fraction. So according to what we said, we added ARB for our patient twice daily for his heart failure. We continued with the beta blocker bisoprolol for rate control, as we have seen that his heart rate is 76. So he is well controlled with beta blocker only. We didn't have to add any digoxin or any amiodarone. We added mineralocorticoid antagonist, eplerenone, for heart failure and reduced ejection fraction. We added some diuretic as the patient had some lower limb edema and basal congestion to relieve the congestion. And of course, we added a new oral anticoagulation for the prevention of thromboembolic event. And he must take the full dose, not the modified dose, as we said that he has the bleeding risk is low and the thromboembolic risk is high. And we added SGLT2 inhibitor for control of his diabetic condition, as well as improvement of his HFrEF condition. And thank you so much.
Thank you, Sri, very much. I think it's very evident that if you have a heart failure with reduced ejection fraction, you have to make it clear that either to rate control with anticoagulation or rhythm control and anticoagulation, whatever you have, rate control, rhythm control, anticoagulations. If you add to your patient some renal dysfunction, for example, usually in heart failure, chronic heart failure patient, the eGFR is low. So what's your advice for controlling the anticoagulation for such patients? Or such patients may need to have a left atrial closure device for this patient. What this is for this kind of patient? How can you, if you are afraid to give anticoagulation with some form of bleeding?
In patients with atrial fibrillation and CKD, we have to modify the dose of oral anticoagulation. For instance, if we are going for Rivaroxaban, we reduce the dose from 20 to the 15. If you are going to the Dabigatran, we reduce the dose from 150 to the 110. But as long as your GFR is not below 15. So if you are having a GFR below 15, it's contraindicated to give NOAC at all, whatever with dose modification. You should have a NOAC, a GFR above 15, so you can use the modified or reduced dose of new oral anticoagulation. And I want to hear, of course, Professor Barnes' concern.
I agree with everything that you just said. The one thing I would add is patients with heart failure, where we're often diuresing and their renal function fluctuates, I personally find that that's a place where Apixaban is often an easier drug to use, because it doesn't mean that I don't have to worry quite as much about constantly changing the dose. And of the oral anticoagulants that we use for AFib, it's the one that has the least renal clearance. So I'm less concerned about it building up and causing bleeding, bleeding risk. That's the opposite of, say, dabigatran. And I think I showed one of those slides where 80% renal clearance for that drug. If you diurese and that creatinine goes up, that's a drug that's more likely to start to build up in the system. So I tend to use more Apixaban in my heart failure patients just because of that fluctuating creatinine.
Dr. Shem, Dr. Walid.
Shukran, Dr. Sharif. Thank you very much for a wonderful presentation. When do you think this patient may be a candidate for rhythm control to convert him to sinus rhythm, whether medically or with catheter ablation?
So the guidelines are clear regarding the rhythm control. It's the patient preference. So you should offer the patient sometimes, especially if this atrial fibrillation was not long-standing, we can see some patient with improvement of ejection fraction or restoring his sinus converting into sinus rhythm. So we should offer to the patient trial to having a rhythm control as a preferred strategy for him. Regarding what we are going to use for the rhythm control, either catheter ablation or the antiarrhythmic drug, this is the patient preference, as we have seen from the guidelines. But usually, if it is a young patient having a dilated cardiomyopathy and this ejection fraction is not long-lasting, he will benefit from restoring sinus rhythm instead of keeping him in atrial fibrillation. But we see patients with long-standing heart failure for ischemic cardiomyopathy or neglected valvular. Usually, we fail to restore them into sinus rhythm, And if they return into sinus rhythms, they are reverted within a couple of months or few times into, again, atrial fibrillation. So if you're having a young patient with dilated cardiomyopathy and hopeful, I think we should offer him this the strategy for rhythm control.
Barnes.
If I may add something, usually, or in case of doubt, sometimes imaging with MRI and seeing the degree of atrial fibrosis would be a predictor of the possibility of maintaining this cardiac rhythm or failure of this rhythm control in the first place. So I think in these cases, maybe especially with cardiomyopathy and possibility of muscle disease, MR imaging would be helpful in deciding which strategy from the first place.
Barnes?
I don't know if you have a comment on this.
A comment from Dr. Barnes.
So we are using more cardiac MRI than we have in the past. I think we're trying to figure out for atrial fibrillation exactly when it's useful, but I'm certain that it will have a role. It's still being defined here in the States. The one comment I was going to make on the rate versus rhythm control, I agree with everything that was said. The one thing I always remind the residents and the students when I'm teaching is sometimes atrial fibrillation is the reason that those patients have a cardiomyopathy. And so when the patients present with AFib and rapid ventricular rate, I always have to ask myself that chicken and egg question. Did the AFib lead to cardiomyopathy through tachycardia-induced cardiomyopathy, in which case rhythm control, rate control is paramount? Or is it resulting from a decompensated cardiomyopathy, in which case that patient may need the fast heart rate, and I need to focus on afterload reducing, diuresis, reduce the stress on the heart, and then the AFib can get under control. So sometimes that's an important distinction to have.
I'm asking about if we decided to cardiovert or to re-achieve a sinus rhythm. What's the appropriate time? Would you recommend that early or after some time of improving hemodynamics, decreasing myocardial stretch to increase the chance of having sinus rhythm and to maintaining it in sinus rhythm? For how long should we wait on anti-failure treatment before considering cardioversion?
So let me see if I get your question clear. You are talking about a patient having acute atrial fibrillation and he has a heart failure, or a patient like this presenting to you and you don't know exactly.
Presented with decompensated heart failure and atrial fibrillation.
Acute atrial fibrillation.
Decompensated atrial fibrillation.
Decompensated heart failure and uncontrolled atrial fibrillation. This is the place for IV amiodarone for controlling of your atrial fibrillation. Of course, after doing it, if you are planning to rate control, not to cardiovert. So as we can, if we review the slide for the guidelines, according rate control in HFrEF patient in acutely decompensated and having a rapid atrial fibrillation, IV amiodarone is a class 2A indication in this type of patient. So I don't think it's proper time to you have to stabilize your patient unless, as Professor Barnes, sometimes the cause of decompensated heart failure is acute AF. So if you are sure that atrial fibrillation is a recent onset atrial fibrillation, it's better to go cardiovert your patient, or if he is hemodynamic unstable, or you can do a TEE followed by the cardiovert IV antiarrhythmic if your patient is hemodynamic unstable.
Sharif or Dr. Barnes, if you don't have an atrial fibrillation and you have a heart failure with reduced ejection fraction, 25%, is the liability of electrocardiographic thrombi or the liability of AF coming to these patients, not AF, but particularly the thrombi. This could be an indication to give anticoagulant as a prophylactic anticoagulant in order, as cause of death of the patient mostly maybe either VF or a patient pulmonary embolization, most common cause of death of this kind of HFrEF patients. Do you recommend to give them anticoagulations for heart?
We tend to reserve anticoagulation in patients with heart failure either to those who have severe heart failure. I'm talking an EF of 15% or less.
Yeah.
Or in patients who've had a very large anterior MI that may be presented late. So we're really concerned that there's not going to be recovery of that myocardial wall function, in which case those patients that will often give maybe a 4 or 6 week course of anticoagulation to see how they do. But we don't routinely anticoagulate most of our heart failure patients.
But warfarin, not NOAC.
Yeah, traditionally we're using warfarin. If you're talking about the STEMI patient.
Yes, large anti-arterial or severe heart failure, 15%.
Yeah. So the severe heart failure patient, I am seeing my colleagues using my heart failure colleagues using Apixaban in that case. In the STEMI case, I do find they tend to use more warfarin, although you could make the argument, right, from the Augustus trial that if you put them on Apixaban and your antiplatelet therapy for the STEMI, that perhaps you could reduce bleeding risk. So I think it would be justifiable, but I do still see a lot of warfarin in that situation.
Okay. Any more questions? Okay. Thank you very much to Sharif for this wonderful case and interactive discussion. You'll be with us till the end. After Dr. Barnes and Dr. Sharif case, now we're coming to the last speaker, Dr. Shihab Al-Atrabi, Lecturer of Cardiology in Shams University, and recently elected as EPCI Young National Ambassador of Egypt. Congratulations, Shihab is going to give us a case, atrial fibrillation with a stroke, and then go into action.
Thank you, Professor Mohammed. This is a case of AF with stroke. We have a 74-year-old male. He has a non-valvular AFib. Now this terminology is not used. He's a diabetic type 2. He has moderate renal impairment, 46 milliliter per minute estimated GFR. He's not a smoker, neither is a hypertensive. His hemoglobin A1C is 7.2%, LDL 110, serum creatinine 1.8, estimated GFR 46. His INR was 1.4. He was on warfarin, and he presented with acute ischemic stroke. As we know, the CKD alone is associated with 30 to 60% increase in the risk of stroke, and diabetes is associated with twofold increase in the risk of stroke, and AF is associated with fivefold increase in the risk of stroke. So he has all three together, so he has a very high risk of developing stroke. This was his MRI, and transesophageal echo revealed a left atrial appendage thrombus in a windsock shaped left atrial appendage. He was on vitamin K antagonist, 5 milligrams per day, metformin 1000 milligrams per day, rosuvastatin 10 milligrams, and bisoprolol 2.5 milligrams. So our further step here is that we should stop the vitamin K antagonist and revert to a NOAC better. As we know from the guidelines that NOACs are preferred than the oral than the vitamin K antagonist, and also in the ACC guidelines. And he has a high Has-Bled score, as we will see. We have some modifiable bleeding risk factors here: the hypertension, concomitant non-steroidal antiplatelets, excessive alcohol intake, the non-adherence to oral anticoagulant, which we suspect here, or maybe he's not taking it regularly, or taking sometimes 2 tablets and 2 days not taking, especially in this old age. The INR should be in the target therapeutic range more than 70%. And we should have an appropriate choice of oral anticoagulant and correct dosing. Maybe he's not following up. Maybe this is not the correct dose for him. So vitamin K antagonist was stopped, and decision was made to switch him to a NOAC. As we know, there is reduced major bleeding and ischemic cardiovascular events in the real world with NOACs versus vitamin K antagonists in the elderly patients with AF. We see it with Rivaroxaban, Dabigatran, and Apixaban, all in favor of the NOAC more than vitamin K antagonists. And the patients with renal impairment in phase 3 NOAC trials, as you see here in the Rocket AF trial, was 21%. In the Aristotle trial, 16.6, in the Engage AF, 19.5, and in the RELY, 18.9. So almost the same percentage in the renal impairment patients. Regarding CHA2DS2-VASc score, it was more than or equal 3, more in the Rocket AF, and 45% in the Aristotle and the RELY. The renal function with NOACs versus warfarin, the use of NOACs was associated with a reduced risk of progressive decline in the renal function regarding the decline in the GFR, the doubling of creatinine, acute kidney injury, and kidney failure were all in favor of NOACs. The question here is when to give the NOAC, after 1 day from the event, 3 days, 6 days, or 12 days. This patient had a mild stroke with mild neurological deficit, and there was no clinical worsening of the case. And in the ERA guidelines of 2018, recommending restarting or starting the NOAC more than or equal 3 days after the stroke onset. And do you think, are all the NOACs the same for this patient? You should use Rivaroxaban or Apixaban or Dabigatran. As we see here, the patient has an age more than or equal 75, so 2 points. He has stroke, another 2 points, diabetes, 1 point. So he has a CHA2DS2-VASc score of 5. We should consider the age, frailty, renal impairment, polypharmacy, and other comorbidities. We should choose the proper anticoagulant with the correct dose, renal function, according to renal function, and the adherence. Regarding a different CHA2DS2 score patient distribution in the phase 3 trials, the Rocket AF had 87% patients with CHA2DS2-VASc of 3 to 6, RELY 32%, and Aristotle of 30%. Regarding the elderly patients, more than or equal 75 years old with AF, nearly the same, about 30 to 40% in all the trials. So all the trials had the same age of these patients and the same percentages, nearly. And the same mean CHA2DS2 score for the patients more than or equal 75, around ranging from 2.7 to 3.7, so they're nearly the same. So how can this patient be protected? He has moderate renal impairment. Regarding selecting the dose, this patient has a creatinine clearance more than or equal 30. He's not more than 80 years. He's not less than 60 kilograms. And his creatinine is more than 1.5, but if we have more than or equal 2 of these, you use 2.5. He has only 1, so he can use the 5 milligrams twice of Apixaban. Regarding Dabigatran, he should use the 110. And regarding the Rivaroxaban, he should use the 15 milligrams once daily. So what about the compliance? Regarding this patient, in real life data, the Rivaroxaban was used once daily in 94%. As you can see, some patients take it twice daily, and that's a big problem. The Apixaban in 70% take it twice daily. The warfarin, 86%. So my take-home message is that NOACs are good for elderly patients. They reduce mortality, stroke, systemic embolism, and life-threatening bleeding. The comorbidities, particularly the renal failure, diabetes, need special attention, and NOAC treatment is good for such patients, especially in reducing renal deterioration. The dose of NOAC treatment must be carefully selected, largely according to renal function to optimize the results. The adherence to therapy is essential, and once daily dosing seems to be the best in this context, and I want to discuss this with you. What do you think? Which NOAC for this patient? Thank you.
Thank you, Shihab, very much. Shihab, can you bring, can you share a screen again? I want to see the slides of the timing of those 137 of the stroke. This is very important, Gab discusses, because this is important. Usually, it's usually missed by most of the colleagues when to use the NOAC according to the neurological status, because this is also, most of neurologists doesn't know this. So acute stimulation, can you explain to us? Yeah, can you explain to us to this slide, please? TIA,
yes. If he has the TIA, you don't give it right away. You wait for 1 day after the stroke onset, and according to the stroke score, they have a score, either mild, moderate, or severe. If it's mild, you wait only 3 days. If it's moderate, you wait 6 to 8 days. Some say 6. And you do a CT to exclude any hemorrhagic transformation before starting the NOACs on this day. And also the same in severe. You wait 12 days and you do a CT before starting the NOAC to exclude any hemorrhagic transformation. But in the mild, you don't need to do a CT because it's a mild stroke. The risk of hemorrhagic transformation is very low.
If I may say, regarding the size of the infarction, even if it's large, sometimes even if you don't have started hemorrhagic transformation, but the risk is still there. So that is why they are waiting for quite a bit longer time, like 12 to 14 days, because even if the transformation did not start, but it is still pending or can occur with large cerebral infarctions.
Afashami, usually I remember myself 1, 3, 7, 14 to be easy for me. Okay, off screen, Shihab again, stop screen. Browns, there's a question coming from the audience here, attendee, regarding the type of NOAC used in stroke and the risk of bleeding. Is bleeding is more with the Rivaroxaban or dabigatran more? Which one? Because you have now 4 drugs in the market, and we have 4 trials, Rely, Rocket, Engage, Aristotle. So how can you choose the best drug for the patient's stroke?
Yeah, I think there's a couple important points. The first is, as a class, all of these drugs significantly reduce the risk of intracranial hemorrhage compared to vitamin K antagonists like warfarin. To me, that's one of the most important points. So I was really glad in your presentation where you brought that up. This is somebody who should switch away from a vitamin K antagonist and over to a direct oral anticoagulant, any one of those. I am not aware of any high quality data comparing the intracranial hemorrhage risk between them. So I don't personally differentiate. I think the points you brought up in your presentation were excellent. Renal function dosing and once versus twice a day dosing, which is the patient going to be compliant with. And then, of course, when after this stroke do you start it? And the symptoms sort of mixed with the imaging. And I always work closely with my neurology colleagues to sort that out. But to me, those are the important points. Whether you choose Riva or Apixaban or dabigatran is less about the stroke and is more about those other factors.
So regarding the once or twice, the question of Dr. Shihab. So if there's a compliant, non-compliant patient, do you prefer once? Or is afraid of bleeding, so you can take twice with less bleeding? Browns, we need your answer.
Yeah,
you have an answer.
There is no right answer. It's talking with the patient, and I'll tell you, I find that the once a day versus twice a day is a bigger issue in people who I'm worried about compliance than the the perhaps lower bleeding risk of Apixaban. So if I'm worried about compliance, I'll usually reach for Rivaroxaban first, being it once a day. If I know that there's extracranial bleeding risk, maybe it's GI bleed, or in a woman, it could be GU bleeding or vaginal bleeding, that's when I might move more towards the Apixaban option.
Yes, some people argue for those non-compliant patients that if you are giving it once daily, then if he would miss that one dose, then you are leaving him for another 24 hours without anticoagulation, then missing one dose is better than missing 2 days. So still people arguing this.
Yeah, and I think it's a good argument. If they're taking other pills, I usually try and get them to use a pill box or something else. Twice a day is hard, and 3 times a day is near impossible. So it's tough no matter what you do. I'm not sure there's a right answer.
Dr. Walid Ammar.
All of us know that we are in a paradigm shift in acute stroke management nowadays. And we have an increasing number of patients who receive fibrinolytic therapy for acute strokes. When to start oral anticoagulation after fibrinolytic therapy, and to assess severity or the chance of intracranial hemorrhage after fibrinolytic therapy? The first question, please, to all of us.
Yeah, it's a really good question. At my hospital, that's managed by our stroke neurology colleagues, and they'll typically use heparin first and then switch over to an oral agent, because with heparin, they know they can turn it off quickly. So we tend to start heparin the same day that the fibrinolytic therapy is given, or the next day. And then after about 24 to 48 hours, we'll switch them over to an oral anticoagulant. I don't know if that's right or wrong, but that's the practice I've seen most often.
But if you are going to do endovascular intervention, how can you manage this? When do you give the drug? If you have an acute stroke and you are going to do intervention, this is adding to the question, Dr. Walid. Are you giving heparin, or you doing removal of the thrombus and then you give NOAC? When?
Yeah, so at our hospital, they tend to use heparin post-procedure to make sure that there's no bleeding, and then they switch to the oral agent, after, usually it's about 48 hours after the procedure. So we tend to use heparin more as an intermediate agent.
Another point is that 2 points mentioned in the ESC guidelines in acute stroke management, and they need your inputs regarding 2 points: that heparin and low molecular weight heparin are not recommended in the acute phase of stroke management. The second is, during the period of waiting for NOAC, which may be 6 days or 12 days, we give patients antiplatelet aspirin. This is what was mentioned in the guidelines. What's your inputs in these 2 points?
Yeah, no, I think they're very good points. Remember that when you have stroke in the absence of atrial fibrillation, there is not evidence for anticoagulation. So I was thinking more about the person in whom we know that they have atrial fibrillation and they have a stroke, and so you're trying to provide some bridging there. But I think this is an area where understanding exactly when to start these drugs, we have some guidance, but I'm not sure there's a lot of prospective data to really guide us. And so whether you choose 2 days or 3 days or 7 days based on the severity, I think the structure that was put forth by Dr. Shahab makes a lot of sense to me. I rely on my stroke colleagues to help me make that decision, because they manage those patients in the acute setting far more often than I do.
So in your practice, you don't prescribe aspirin in the first 1 week at least before starting oral anticoagulation and moderate risk patient. You don't give aspirin.
I tend to not see those patients until afterwards. And so they're usually not on aspirin temporarily. They're usually just started right on the anticoagulant. But the decision-making for that is usually left up to my stroke neurology colleagues.
Dr. Sharif Wag, do you have any question?
Thank
Sharif.
you.
Okay.
Completely clear.
Okay, thank you. I think we come to the end. We spent 2 hours. Actually, it was very fruitful 2 hours for me, I think for most of the panelists, speakers, and the audience. We started by 86 attendee, now reaching more than 210, which is, I think it's a good number. You know, it's an excellent, one of the excellent webinars I have. Thanks, Dr. Barnes, for your contribution. I vote for you. Actually, it's the best of ACC. I promised the Egyptian that I bring you to this webinar regarding the oral anticoagulation and the F guidelines, and even in the discussion of the other cases. Thanks, Dr. Shihab Al-Atribi and Dr. Sharif Wagdi for these cases of heart failure and stroke. Thanks for my colleagues, Dr. Professor Hisham Abareen and Professor Walid Ammar for their help and the panelists. I think all of us enjoyed this webinar, and thanks to Pfizer who sponsored this one. We are not biased with Apixaban, although it's most of the powerful drugs, but actually we discuss all types of the NWAC, and we can just discussing which is better for the patients, and we have to investigate the patient properly. You have to take the Shattra score, the HAS-split, know the guidelines, know the tables. I think it's important to have your in your pocket guidelines, these graphs, because these tables sometimes are missed. For me, for the stroke, I have to look usually to myself. That's why I remember 1, 3, 7, 14 for the time. Usually for even the heart failure, as Sharif said, you have to remember what the guideline changes. Even the terminology of atrial fibrillation have been changed in the last guideline. Finally, I'd like to thank also ICOM for Zainab and Amr for technical support and for preparation. And have a nice weekend, Barnes, for this year. And I hope to see you physically as soon as possible. Goodbye.
Thank you so much. Bye-bye.
Bye-bye.
Thank you.
Bye-bye.